Thank you for staying with us this hour. You are watching In Time TV's On the Edge. I'm Dr. Jonas Moses. This hour we are talking about reflex sympathetic dystrophy, complex regional pain syndrome, that is RSD, CRPS. And with me to discuss this is Dr. Doron Feinsilber, our On the Edge internal medicine correspondent. And just before the break we were talking about, you were beginning to talk about differential diagnosis of patients that come into your clinic and the things that you're thinking about in the course of which you come up with a diagnosis of RSD.
Right. So when we left off last time, I talked about patients who either might be exaggerating their syndromes, people who actually gain a psychological edge from playing the sick role. You know, let's say, oh, I get to sit at home for a couple of days, or
Well, there's a litigation going on, and we're
hopefully not the case, but
often it is with RSD.
It could happen. But here's the thing. So then I think to myself, okay, if there is an organic issue, we think about things like fibromyalgia, mixed connective tissue disease, even more rare disease like scleroderma, which is again, it's all autoimmune, where you have an antibody against something called SCL70. It's an anti-topoisomerase antibody. And so we start thinking about all these different types of things. Even people taking statin drugs, which is very common right now, because a lot of these patients who are hypertensive and diabetic need to have an LDL cholesterol level of below 100, or even below 70, depending on how many comorbidities they have. And in some patients, they can get pain all over the place. Their CPK levels going to be elevated, which is the creatine phosphokinase level, because that means that there's muscle breakdown, and that tends to happen in the distribution of the shoulders, the arms, the legs, even just above the kneecaps. So we have to think about, are those going to be things that are important? Patients who have fibromyalgia, who tend to have disrupted sleep patterns, who don't actually go into REM sleep properly, they tend to develop these syndromes too, and their CPK levels are also elevated. So now if we try to rule out all those things, gout, for example, which is where you have uric acid crystals that are developing, or pseudo-gout, which is also calcium phosphate kind of complexes that can build up throughout the joints. Patients who are chronically anticoagulated with warfarin, and they can get some bleeding into the joints and have a breakdown of the blood. It'll go into bilirubin. It's called hemosiderosis, which means that you have pain in the distal phalanges or in the fingers. So then you start thinking to yourself, wait a minute, so you're going 1, 2, 3, 4, thinking that now that's not making any sense. Patients who have tendency to develop blood clots, or people who are post-operative, who have been immobilized, you start thinking to yourself, well, do they have a DVT, or deep venous thrombosis, and that can result in a pulmonary embolism, and you have to watch out for those things. Even on physical examination, once I do a full skin and musculoskeletal exam, even with a patient who has some calf pain, the first thing I do is I take the foot and I bend it back like this, and that's called the Homan sign if they have a pain when I actually flex the foot back. So once I determine that all those things are not the case, now a lot of clinicians have a big question mark over their head, and they say, what can this possibly be? Well, I'll bring up a case that I had in the hospital about a year ago. This was a 70-some-year-old patient who had an open reduction and internal fixation of the hip. Like I said, an older lady, and she had to be immobilized, and obviously a surgery is a very invasive procedure. And she noticed that when she followed up with us in the outpatient clinic, that she had this horrible pain that wasn't just at the incision site, but even a little bit further up. And we're thinking to ourselves, well, okay, it's probably some post-operative process, and doesn't seem to be a big deal. But here's the interesting thing, is that what a lot of clinicians don't know is that when you have a surgery, that you have the sympathetic nervous system that gets shot into overdrive. And this tends to happen at the site of the trauma. When that happens, you actually get almost an exposure of these sympathetic nerves that are going to cause chronic pain. And it tends to get worse over time unless it's addressed quickly. What we tend to treat that with is a substance called phenoxybenzamine, which we talked about a little bit earlier in the show. Again, it's a reversible alpha blocker. That means it blocks the alpha receptor that tends to be predominant in the sympathetic nervous system. So that will try to kind of ease down that pain. So a lot of surgeons tend to know this a little bit more often now because they're post-operatively, they go into the patient. There's a lot of remodeling that happens when you finally close a wound, and that tends to happen. And that's usually what they give. And I think we're going to talk a little bit later in the show about the other types of therapies that are given for this.
Yes, just on the tail end of that, because you're plainly a rigorous history taker, it's easy in a busy practice setting to miss some of these points. And when I was talking to Dr. Kirkpatrick, just to remind our viewers, if you're just tuning in, Dr. Anthony Kirkpatrick is the chair of the Scientific Advisory Committee and the Director of Research for the International Research Foundation for RSD-CRPS. And I had a chance to speak with him by phone this morning. He points out that you must know the diagnostic criteria. There were criteria established in 1994 and 95.
Right.
It's critical to know the sympathetic nervous system. So if you've been in practice a while, if you've been away from the information knowledge bases, it's important to go back and review these. And important to remember that you need to identify. First, there's going to be some noxious event where the symptoms outweigh what you would expect from the injury. A pinprick that turns into pain everywhere, diffusely all over your arm and your chest. Identify some dysfunction of the sympathetic nervous system, like cold skin, hot skin, and attempt to measure these dysfunctions. If you can measure them at all, that's very useful to have as a baseline. Frequently, Dr. Kirkpatrick said to me, by the time this is established, you have pain in both extremities, so it's very difficult to have a control. You want to rule out other causes that can give the same kind of symptoms as RSD, and you mentioned DVT. And then he said, excellent history taking is critical. That's absolutely critical.
Oh, it absolutely is critical. And a lot of times that when patients see me even in the emergency room, that's where the initial evaluation is really what makes a difference. Because again, there's so many different causes of chronic pain syndromes that you have to really be very noteworthy and take your time and be meticulous with the patient and try to figure out exactly what's the prevailing issue. Because like I said, there's probably a good list of 10 or 15 things that are usually on the clinician's mind before they even consider RSD. And again, but it's true, the RSD isn't in the medical community referred to as a zebra. It doesn't happen all the time.
We are going to go to a commercial break. This hour is flying by. It's an interesting topic. I'm Dr. Jonas Moses. With me, Doron Feinsilber, MD. And with this hour, we are talking about RSD-CRPS. Stay tuned.